There are currently 45,000 highly trained healthcare professionals sitting entirely unemployed in Ghana right now.
Yeah, it's a massive number.
Right. We are talking about 45,000 registered nurses and midwives who have the education, the skills, and the drive to save lives, but they are effectively stranded by this completely broken labor deployment system. And they are sitting idle at the exact same moment that massive legacy international aid organizations are pulling out of rural areas, which is leaving millions of people without access to basic medical care.
It is a staggering contradiction, honestly.
Yeah.
I mean, you have this immense surplus of human capital, completely isolated from a desperate life or death demand for that exact capital.
Yeah.
We see this all the time in macroeconomic health policy. The legacy systems are fracturing, and traditional foreign aid is contracting. And, when those top-down funding mechanisms recede, the communities left behind are forced into a corner.
They really are.
They either collapse under the weight of their own unmet needs, or they are forced to radically innovate.
And that radical innovation is exactly what we are going to explore today. You might be listening to this while prepping for an institutional grant committee meeting, or maybe you are working in the trenches of global development. Or, maybe you are just insanely curious about how we actually solve seemingly unsolvable systemic infrastructure problems without just throwing money into a bureaucratic black hole.
Which happens a lot,
Dude,
unfortunately.
so much. But whatever brought you here, this deep dive is for you. We are analyzing a phenomenal stack of sources today.
We really are. We're unpacking a highly sophisticated investment narrative today. The core materials are drawn from the Strategic Oversight and Compliance Audit of the Northern Health Shield, as well as this fascinating financial document called the Dollar Challenge Matrix.
Yeah, the matrix is wild.
It is. And the ultimate initiative we're looking at is titled Health Sovereignty, the Northern Health Shield Investment Case.
So let's set the stage a bit before we dive into the deep mechanics of the medicine and the money. The organization orchestrating this is called Give Basic Needs, which serves as the operational arm of the Colussi Family Foundation.
Right.
And the geographic focus is northern Ghana, which is a region dealing with that perfect storm we just mentioned, vanishing international aid and a massive surplus of unemployed medical talent.
Yeah, the exact place you need a new model.
Exactly. But to understand what Give Basic Needs is actually doing, we have to understand what they are deliberately not doing. They aren't just flying in, slapping together a few brick-and-mortar clinics, taking some photos for a donor brochure, and flying out.
Oh, far from it. The Northern Health Shield represents a fundamental structural transformation of how philanthropic capital is deployed.
Which is so needed.
It really is. For decades, the global health paradigm in developing regions has been overwhelmingly reactive. You can think of it as a testing and treating
model. Testing and treating.
Yeah. The system essentially waits for a community member to contract a severe illness, whether that's malaria, typhoid, or, severe malnutrition.
Right.
And then that person has to walk for miles or sometimes days to reach a centralized clinic. Once they finally arrive, the clinic tests them. And if they are lucky enough to find the clinic stocked, they receive treatment.
Which is a big if.
A huge if. It's an incredibly expensive, highly inefficient, and frankly, tragic way to manage public health.
It's essentially waiting for the house to be entirely engulfed in flames before you even think about installing a smoke detector. It just guarantees maximum damage.
That's a perfect way to visualize it. And what Give Basic Needs is attempting to do is abandon that reactive posture entirely.
Okay.
They are building a predictive, preventive smart grid of healthcare. They want to move away from the concept of perpetual, endless foreign aid, where a region relies on the generosity of an overseas foundation forever, and move toward a concept they define as health sovereignty.
Health sovereignty. I mean, it's a powerful phrase because it implies absolute ownership. It suggests that the local community isn't just a passive victim waiting for rescue, but rather the actual master of its own medical and economic destiny.
Yes, that is the crux of the entire investment case for the institutional donors. The foundational question this audit attempts to answer is, how do you build a healthcare system that eventually no longer needs you to fund it?
Okay, let's really unpack this, because before we get into the complex supply chains, the blockchain accounting, and the institutional financial models, I want to start with the surprisingly simple philosophy that drives the entire architecture of Give Basic Needs.
Yeah, it's a great starting point.
According to the strategic prompt data we reviewed, their core philosophy is summarized in a single, rather unexpected sentence. It says, "Happy people solve problems more quickly."
I know. When you first read that in a dense, compliance-heavy institutional audit, it sounds almost dangerously naive, doesn't it?
It really does. You open a high-stakes investment case expecting to read about epidemiological vectors and macroeconomic indicators, and instead you get happy people solve problems more quickly.
Yeah.
It sounds like a bumper sticker. But, when you look at how they deploy their capital, it makes profound mechanical sense. Their interventions prioritize community morale and systemic resilience, focusing intensely on the absolute fundamentals, which are food, shelter, and medical services.
Right. It's basically applied behavioral economics. They apply that philosophy directly to the physical architecture of their intervention.
How so?
Well, they aren't just constructing an isolated medical building. They are engineering a whole community ecosystem. And the absolute center of that ecosystem, the thing that draws everyone in, is what they call the anchor asset.
The anchor asset. Yeah, every single rural health hub in the Northern Health Shield is anchored by a mechanized borehole.
Exactly. A deep-drilled, mechanized well that taps into the underlying uncontaminated aquifers to provide continuous, clean water to the surface.
And here is the critical policy detail that acts as the linchpin for the entire community relationship. Water is viewed by the Foundation as a fundamental human right. Therefore, the water from this mechanized borehole is never sold.
Never.
There is no meter. It is shared equally, for free, with all community members.
And if we look at the mechanics of why this matters operationally, it's brilliant. On a purely clinical level, providing free, clean water immediately addresses a massive portion of the region's water, sanitation, and hygiene needs.
Right.
You are preemptively stopping waterborne diseases like cholera and dysentery before they ever require medical treatment at the clinic. It is the literal first line of defense.
That is the preventive smart grid in action. You don't have to treat cholera if they don't drink contaminated water in the first place.
Exactly. But the secondary effect is where the real genius lies, I think. From a sociological standpoint, that free water acts as a massive, irresistible community magnet.
Oh, for sure.
In a region where securing clean water is a grueling daily struggle that dictates the rhythm of life, a reliable, free, mechanized borehole becomes the absolute epicenter of the village.
Let's use an analogy here. It's almost like the community is a biological body, and the health hub is trying to act as the immune system. But an immune system is useless if it's isolated from the bloodstream.
Right.
The borehole is the mechanism that connects the clinic to the lifeblood of the village. It draws the people in.
I really like that analogy. You are building structural trust by lowering the activation energy required to interact with the medical facility.
Yeah.
Think about the friction involved in traditional rural healthcare. If the clinic is just an intimidating, sterile building that you only visit when you are in excruciating pain or fearing for your life, the psychological friction to seek early preventative treatment is incredibly high.
Totally. People will put it off until it's too late.
Exactly. But if the clinic is literally the place you go every single morning to get your family's daily water, the environment becomes normalized.
So checking in with the nurse about a child's lingering cough or a weird rash becomes a casual, low-friction interaction while you're filling your water containers.
Yes. And it drives consistent, predictable foot traffic. And that consistent foot traffic is the only way a preventative model survives.
Because you can't force it.
Right. Health sovereignty cannot be mandated from a boardroom in another country. It has to be adopted from the inside. If the community doesn't feel a sense of ownership, utility, and deep gratitude for the facility, the moment the foreign funding dries up, the building just falls into disrepair.
So the physical anchor of the borehole builds the social capital that is absolutely necessary to sustain the medical capital.
100%.
And that transition from the physical anchor to the human anchor brings us back to those 45,000 unemployed nurses we talked about. Because a building and a well don't run themselves.
Right.
This is where the model truly pivots from traditional charity to a localized social enterprise.
Yeah. The Northern Health Shield essentially transforms unemployed health professionals into localized economic engines. The protocol dictates that a female registered nurse lead is appointed to manage each health hub.
But she isn't just hired as a low-level employee of a massive non-governmental organization, right?
No, not at all. She is established as an entrepreneur.
She is essentially the chief executive officer of her specific rural health hub.
Exactly. She is the executive decision maker on the ground. She is supported by a localized staff of 2 office personnel to handle the administration, but the ultimate responsibility and the ultimate opportunity for leadership rests with her.
That's a huge deal.
It is. And to get this enterprise off the ground, the Colussi Family Foundation provides a very specific financial launchpad.
Okay, let's break down this medical capital grant, because the numbers in the audit are fascinatingly precise and frankly surprisingly low for the impact they claim.
Go there.
The foundation provides a one-time grant of 171,000 United States dollars.
And in the grand scheme of international institutional aid, where development budgets frequently run into the hundreds of millions of United States dollars for a single region, 171,000 United States dollars is an incredibly lean, efficient number to establish a permanent, self-sustaining healthcare beachhead.
Yeah, it's nothing compared to the big players.
Yeah.
Here is the specific breakdown of that capital. 162,000 goes directly toward the physical construction of a 3-room clinic and the procurement of the full initial medical stock.
Right.
Then 6,500 goes toward that deep drilled mechanized borehole we just discussed. And 2,500 is allocated for technology.
That technology budget is lean, but as we'll explore later, is doing a tremendous amount of heavy lifting regarding global satellite communication and data verification.
We will definitely get to the tech stack, but here's a part of the financial model that really made me stop and reread the audit. On top of that infrastructure grant, the foundation provides a $30,000 stipend for the registered nurse entrepreneur. However, the mandate states this is strictly for year 1 only. After 12 months, the foundation completely cuts off her salary.
Right, and this raises an incredibly important point about the psychology of sustainable development. The year 1 only stipend cliff is the most controversial yet most vital aspect of their entire philosophy.
I have to push back hard on this. If the ultimate goal is to support global healthcare, why impose such a brutal financial cliff after just 12 months?
I know it sounds harsh.
It does. You take a woman who has been unemployed, you make her the chief executive officer of a brand new rural clinic, and just as she's getting her bearings, you pull the financial rug out from under her. How is that supportive?
I completely understand the shock, but you have to look at the historical alternative. An endless guaranteed salary paid by a foreign foundation is the exact definition of the traditional aid trap.
Okay, go on.
If the foundation promises to pay her salary forever, they are creating a permanent, fragile dependency. What happens in year 3 if the Colussi Family Foundation's endowment shrinks, or they decide to pivot their resources to a different crisis in a different country?
The clinic collapses instantly because the nurse can no longer afford to work there.
Exactly. The clinic becomes an endless sinkhole for foreign capital, constantly requiring bailouts. The forced transition after year 1 is the absolute mechanical core of health sovereignty.
So it forces her hand, essentially.
It forces the registered nurse entrepreneur to build a functional, self-sustaining business model within that first 12-month runway. It aggressively transitions her mindset from a passive recipient of a charitable salary to an active strategic manager of a community health enterprise.
Okay, I see the logic, but the math still has to work. How does she actually survive year 2? How does a clinic in rural northern Ghana become financially self-sustaining without resorting to price gouging the very impoverished people it is supposedly trying to help?
It's a great question. The audit outlines 2 interconnected revenue streams designed to activate in year 2. The first is clinical service fees. Now, they are incredibly careful about the pricing psychology here.
Right.
The community members do pay for medical services and medications, but they are charged at a small ethical markup. It's essentially wholesale level pricing.
So the clinic isn't looking to generate massive corporate profits or declare a dividend. They are just trying to cover base operational costs and replenish the medical stock.
Right. And requiring the community to pay a manageable wholesale price reinforces that sense of ownership. People value what they pay for.
True.
But wholesale margins aren't enough to pay a competitive salary for a highly trained nurse and 2 administrative staff. That's where the second revenue stream comes in, and it's where the smart grid really flexes its multisectoral design. It is the medicinal forest.
The medicinal forest. This completely blew my mind. Adjacent to every single clinic, they secure land and cultivate cash crops.
Yeah, they engineer an agricultural cooperative directly tied to the clinic. They grow specific medicinal and high-value crops, and these are sold at market prices, not wholesale prices, to external, regional, or even international buyers.
Oh, wow.
And this generates external capital that flows back into the clinic's treasury, heavily subsidizing the medical operations and securing the wages of the staff, especially during seasonal shifts when local patient engagement might naturally slow down.
That is brilliant cross-subsidization. The broader commercial market pays full retail price for the cash crops, which creates the financial buffer that allows the local village community to pay wholesale prices for their life-saving medicine.
Exactly. It creates a localized economic engine that doesn't rely on the charity of a donor in New York or London.
But wait, let me push back on the human element again. We are asking a single female registered nurse to act as a frontline clinician diagnosing diseases, a chief executive officer managing a staff and a clinic's finances, an agricultural manager overseeing a commercial farm, and, as we'll see later, a data clerk managing satellite uplinked enterprise software.
It sounds like a lot.
It sounds like an absolute recipe for catastrophic burnout. How does the foundation prevent these women from just collapsing under the sheer weight of this multi-sectoral ecosystem?
That is the most critical vulnerability in any localized enterprise model, and it's exactly why the modular design is so important. The nurse is the executive lead, but she is not out in the sun physically planting cashews, nor is she building the uninterruptible power supplies.
Okay, that makes sense.
She is trained to delegate within a cooperative framework. The medicinal forest is managed by a dedicated local cooperative team. Her role is oversight and resource allocation. The two office personnel handle the data entry and administrative load.
Right.
The Foundation's model is explicitly designed to elevate her to an executive management tier, providing her with the software as a service tools like automated accounting and inventory tracking. So she isn't doing the manual labor of 5 different jobs. She manages the managers.
She is conducting the orchestra, not trying to play every single instrument herself.
Precisely. And that brings us to a really expansive part of the strategic narrative. This single hub model, with its free water borehole, its empowered nurse entrepreneur, and its commercial medicinal forest, doesn't just provide rural healthcare.
It does so much more.
It creates a massive, measurable ripple effect across the entire local economy. Give Basic Needs has intentionally engineered this model to align directly with specific global targets, namely the United Nations Sustainable Development Goals.
The United Nations Sustainable Development Goals are essentially the universal benchmark for measuring global progress in the humanitarian and development sectors. There are 17 goals in total, ranging from eliminating poverty to protecting the oceans.
Right.
What is truly staggering in this audit is that the Northern Health Shield is documented as a primary driver for 13 of those 17 goals.
Achieving measurable progress on 13 out of 17 global goals from a single modular rural health hub blueprint is an extraordinary claim for any institutional grant strategist to make.
It is. So let's really dive deep into how they actually achieve this, because it illustrates the profound interconnectedness of poverty, health, and infrastructure. Let's look at Goal 1, which is no poverty, and Goal 8, which is decent work and economic growth.
Okay.
We touched on the job creation, but the audit goes deeper into the macroeconomic theory.
Yeah, when you open a health hub with this specific structure, you are fundamentally altering the local economy by increasing what economists call the velocity of money within the village.
Let's unpack the velocity of money for our listeners. What does that actually mean mechanically on the ground in a rural village in northern Ghana?
Mechanically, the velocity of money is the rate at which a single unit of currency is exchanged or changes hands within an economy over a given period of time.
Right.
In a severely impoverished, highly isolated village, money often stagnates. If a local farmer gets a small amount of cash from selling a crop, they tend to hoard it out of fear, or they are forced to travel to a distant larger city to spend it on basic manufactured necessities.
So it just leaves.
Exactly. In either case, that money leaves the local ecosystem almost immediately. The velocity is incredibly low.
It leaks out of the village economy after just one transaction.
But when you establish this health hub, you are creating an interconnected web of local employment and consumption. The initial construction of the 3-room clinic utilizes local labor and local materials.
Yeah.
The management of the medicinal forest requires a local supply chain workforce. Suddenly, the registered nurse entrepreneur is earning a substantial salary and spending part of it at the local market. The construction workers are buying goods from their neighbors.
Oh, I see.
The single dollar circulates multiple times from the clinic to the farm worker to the food vendor back to the clinic for a wholesale medical fee before ever leaving the village. That compounding economic activity is the velocity of money, and it is the only organic way to lift a microeconomy out of poverty.
And there's a really fascinating technological layer to how Give Basic Needs manages the inflow of this money, which ties directly into Goal 1, no poverty.
Right, the payment systems.
According to the strategic prompt data we reviewed, they utilize blockchain technology. Specifically, they use a cryptocurrency called United States Dollar Coin, which operates on the Ethereum network to handle cross-border funding from the foundation to the local hubs.
This is a vital operational detail that solves a massive friction point in global philanthropy.
Oh, so.
Well, when a foundation sitting in North America or Europe tries to send grant funds to a rural clinic in a developing nation through traditional banking channels, the friction is enormous. You're dealing with multiple intermediary correspondent banks, unfavorable currency conversion spreads, hefty wire transfer fees, and significant delays that can take weeks.
It's awful. I've read reports where up to 20% of international aid is lost to administrative and banking friction. It's infuriating.
It is. A highly significant portion of the intended aid money is essentially eaten by the global financial bureaucracy before it ever reaches the people who actually need it.
Yeah.
But by utilizing blockchain technology, the organization completely bypasses that legacy system.
They just go around it.
Exactly. They use United States Dollar Coin, which is a stablecoin pegged 1-to-1 directly to the value of the fiat currency, meaning it doesn't suffer from the wild price swings usually associated with cryptocurrency.
Right, it's stable.
By transmitting this stablecoin over the Ethereum network, they eliminate those excessive predatory banking fees. The transaction settles in seconds, not weeks, and it ensures that virtually 100% of the allocated funds reach their intended destination.
That is a phenomenal application of the technology. They are using advanced blockchain architecture to directly facilitate Goal 1 simply by cutting out the institutional middlemen.
Yeah.
Let's move to Goal 2, which is zero hunger. This specific strategy actually surprised me. When you think of humanitarian aid tackling hunger, you immediately picture massive white trucks rolling into a dusty village and distributing huge bags of generic grain or prepared meals to crowds of people.
The classic, deeply ingrained image of food aid.
But the audit explicitly states there is no general food distribution at the hub level, no massive handouts of generic maize or rice.
And this is a highly intentional, heavily researched policy.
Why is that?
General food distribution, while absolutely necessary in acute, sudden onset famine or active conflict zones, can absolutely devastate local agricultural economies if implemented long-term in a stable region.
Oh, because of the market dynamics.
Exactly.
Yeah.
If an international agency floods a village with tons of free imported maize, the local farmers who grow maize can no longer sell their crops. You solve the immediate caloric deficit, but you bankrupt the entire local agricultural sector, destroying their livelihoods and creating a much worse systemic crisis the following year.
So how does the Northern Health Shield address Goal 2, zero hunger, without destroying the local farmers?
They use a highly targeted, localized, and clinical approach. The medicinal forest we mentioned earlier cultivates specific, high-value, nutrient-dense crops. The audit highlights the cultivation of cashews. Instead of giving everyone in the village free imported food, the cultivated cashews from their own adjacent forests are strictly utilized for local community members who are medically diagnosed at the clinic as suffering from severe malnutrition.
It is food prescribed as a targeted medicine rather than food dumped as a blanket economic disruption. It keeps the intervention clinical, precise, and entirely locally sourced.
Exactly. Let's examine Goal 4, quality education, and Goal 5, gender equality.
Let's do it.
We already know the hub serves as an active training ground for the female registered nurse entrepreneurs. They are learning complex healthcare management, executive leadership, and digital oversight systems like the enterprise resource planning software.
Right.
But there's a very deliberate nuance to the gender dynamic here that institutional grant committees need to understand.
Because empowering women in a patriarchal society can sometimes lead to unexpected friction if not handled carefully.
Yes. The audit notes that while the ultimate executive leadership of the hub is explicitly female, the registered nurse, like all other operational cooperatives, like the teams managing the medicinal forest and the supply logistics, are intentionally non-gender exclusive.
So they mix it up.
They are structured to ensure a balanced environment for all qualified community members.
That is a very sophisticated, pragmatic approach to gender equality. You mandate and empower female executive leadership at the very top, breaking the glass ceiling of the village hierarchy, but you do not create a secondary class of resentful, unemployed men by excluding them from the broader economic opportunity of the forest cooperative.
Exactly. You lift the women up without tearing the existing social fabric apart.
Furthermore, under Goal 4, quality education, the hub directly tackles a massive, often overlooked barrier for young women: The audit details the deliberate distribution of sanitary pads through the clinic.
Which is huge.
Yeah, this isn't just about hygiene. It is explicitly designed to reduce female student absenteeism.
Period poverty is a massive reason young girls fall behind or completely drop out of their education in rural areas. They simply do not have the supplies to comfortably and safely attend school during their cycle.
Right.
By providing this basic necessity through the Health Hub, Give Basic Needs is directly keeping girls in the classroom. This is a perfect example of how a targeted health intervention acts simultaneously as a powerful educational intervention.
Let's tackle the hard physical infrastructure next. Goal 7, affordable and clean energy, and Goal 9, industry, innovation, and infrastructure. How do you consistently power a modern, digitally connected health hub in a remote region where the national electrical grid is either entirely non-existent or incredibly unreliable?
You have to fundamentally rethink the scale and ambition of your power solutions. The traditional legacy aid approach might be to try and secure a massive, multi-million-dollar grant from the World Bank to build a centralized, localized power station, or a giant solar farm to electrify the entire village grid.
Which takes 10 years, requires endless political wrangling, and is plagued by corruption before a single wire is ever laid.
And it often fails completely.
Yeah.
Instead, the Northern Health field relies on hyper-efficient, highly localized power management.
What do they use?
They utilize advanced, uninterruptible power supplies, essentially massive battery backup systems dedicated exclusively to the hub footprint. The prompt data clarifies that these systems are either tied to the local electrical grid, where it exists, to smooth out the brownouts, or they are replenished directly with dedicated solar power based on the specific geographic location.
So they aren't trying to boil the ocean, they aren't trying to become a utility company for the entire region.
No. They emphasize that while solar is prioritized as capital allows, the primary non-negotiable goal is simply to efficiently power the critical medical equipment and the digital oversight tools inside the Health Hub.
Like the satellite internet routers, the diagnostic laptops, the lighting.
Exactly. They ensure the core medical data flows rather than taking on the impossible burden of building a power station for thousands of homes.
Though the audit did mention they also provide solar streetlights in specific pilot areas like Tajenga, which acts as a safety multiplier, expanding the usability and security of the communal village spaces after dark. It's targeted, resilient infrastructure.
It really is. Now, let's pivot from the socioeconomic framework back to the actual clinical science, because this is where the theoretical model has to prove it can actually save lives in the dirt and the heat.
Right. How does the Northern Health Shield actually shift a vulnerable community from being dependent on reactive emergency medicine to proactive systemic prevention?
They implement a strategy they call the four-layered defense shields. It is a deeply strategic biological approach to community immunity.
Let's walk through the mechanics of these shields. Shield number 1 is the viral shield.
Yes.
This is focused intensely on high-impact vaccinations, and the audit points out a massive, absolute game changer here, which is the specific selection and use of the hepatitis B vaccine and the typhoid conjugate vaccine.
And this raises an incredibly important question about the hidden logistics of rural healthcare.
Tell me about it.
When most people, even institutional donors, think about vaccines, they just visualize the needle going into the patient's arm. They don't think about the excruciatingly complex supply chain required to get that fragile vial from a laboratory in Europe to a village in northern Ghana.
The invisible, incredibly fragile umbilical cord of global healthcare is something called the cold chain.
Yes, most traditional legacy vaccines are biologically delicate. They must be kept at very specific low temperatures, usually strictly between 2 and 8 degrees Celsius, from the moment they roll off the manufacturing line to the moment they're injected.
Which requires an unbroken chain of refrigerated trucks, refrigerated cargo airplanes, massive refrigerated holding warehouses at the ports, and specialized refrigerated lockboxes at the final rural clinic.
Now imagine trying to maintain that unbroken chain of perfect refrigeration across thousands of miles, ending in a rural, sun-baked village where the ambient temperature might regularly reach 40 degrees Celsius, and the local electrical grid might go down 3 times a week.
It is a logistical nightmare. If the clinic's refrigerator loses power for even a single day, the entire batch of vaccines biologically degrades and spoils.
Yep.
You have wasted thousands of United States dollars of donor capital, and far worse, you have left the community completely unprotected against a deadly outbreak.
That is exactly why the viral shield's reliance on the hepatitis B and the typhoid conjugate vaccine is so revolutionary for rural deployment.
Because of their stability.
Yes, these specific biochemical formulations exhibit remarkable ambient temperature stability. Due to their conjugate structure and freeze-dried lyophilization processes, they can withstand ambient temperatures up to 40 degrees Celsius for several days without losing their clinical efficacy.
That is over 100 degrees Fahrenheit.
Yes, this completely removes the absolute necessity for a strict, continuous cold chain right down to the final hub level. It drastically reduces the catastrophic risk of vaccine spoilage due to grid instability, and it entirely slashes the massive infrastructure, logistics costs associated with transporting and perpetually storing fragile medicine in remote areas. It is a triumph of selecting the appropriate scientific tool for the specific environmental reality.
You eliminate the fragile dependency on constant refrigeration, and suddenly, universal vaccination in remote, hot climates becomes economically and operationally feasible. It is brilliant.
It really is.
Let's look at the second shield, the safe blanket.
This layer focuses on mass seasonal protection against pervasive endemic threats that constantly drain the community's vitality.
The audit specifically highlights seasonal malaria chemoprevention for children under the age of 5, as well as mass deworming programs. This seems like it's all about catching the most common, debilitating everyday issues before they compound into severe, life-threatening emergencies.
Exactly. Malaria and parasitic worm infections are chronic, massive burdens in these specific regions. They cause severe anemia, they stunt physical and cognitive development in young children, and they drastically reduce the adult workforce's agricultural productivity.
Right.
By providing the safe blanket of preventative anti-parasitic medication at specific high-risk times of the year, like the rainy season, you are preemptively clearing the healthcare bottleneck.
You are emptying the clinic's waiting room before it even fills up. You're keeping the immune system strong so it doesn't need emergency care.
Yeah. Now, the third shield is conceptually fascinating. It's called the cultural bridge.
A cultural bridge.
This is where that medicinal forest cooperative comes back into play, but this time from a clinical perspective. The audit describes it as an import substitution strategy.
That's a great macroeconomic term. It means instead of importing expensive, foreign-made, manufactured medical solutions for every minor ailment, you cultivate localized, culturally relevant biological alternatives.
Exactly. The medicinal forest cultivates moringa, cashews, and hemp seed. The audit explicitly calls hemp seed a high-protein superfood crucial for maintaining baseline immune function.
Oh, I see.
So they are integrating validated local agricultural remedies to manage chronic health burdens and nutritional deficits alongside modern Western vaccines.
It bridges the gap between traditional community view practices and clinical science. I imagine it builds immense trust with the local elders because you aren't just overwriting their historical local knowledge with imported pills, you are validating it, optimizing it, and integrating it into the formal clinic structure.
Absolutely. However, we need to address the regulatory reality of this. Cultivating hemp is not exactly like planting a row of tomatoes.
Definitely not.
You cannot just throw some seeds in the dirt and hope the authorities look the other way, especially from a strict legal and compliance standpoint.
Right. The audit explicitly mandates that to legally grow the hemp for the cultural bridge, the Medicinal Forest Cooperative must navigate the national bureaucracy and obtain a valid cultivation license from the Narcotics Control Commission for low THC hemp.
That is a critical proof point for any institutional investor reading this case study. Compliance is not optional.
No.
If they ignore that regulatory detail, the government could shut down the entire multi-million-dollar project overnight. Navigating the Narcotics Control Commission shows that health sovereignty requires extreme administrative diligence and legal sophistication, not just good intentions.
And that administrative diligence brings us to the final shield, the societal shield, which we touched on earlier.
Yes, the distribution of sanitary pads to end period poverty and the distribution of condoms for family planning and reproductive health.
It is a comprehensive, holistic defense. You protect against viruses, you eliminate parasites, you cure malnutrition, and you provide reproductive autonomy.
But here's where the narrative gets incredibly intense for the people actually writing the massive checks.
Right, the donor.
You can have the most beautiful, holistic philosophy in the world. You can have temperature-stable vaccines and thriving medicinal forests. But if you are an institutional donor, if you are a major philanthropic fund or a government development agency, you demand absolute, verifiable proof that your money is doing exactly what you were told it would do.
Accountability. Historically, in the foreign aid sector, that level of accountability simply did not exist. The process was essentially a black box.
Completely opaque.
Money went in, disappeared into a maze of ministries and non-governmental organizations, and maybe a year later, the donor received a glossy report with some nice photos of smiling children and some vague, unaudited statistics.
The classic trust us model of philanthropy,
Yeah.
which is exactly why so many donors are pulling out. They are tired of the opacity.
But Give Basic Needs has instituted a 100% transparency mandate. And they achieve this using a highly sophisticated, centralized digital backbone that ensures donor-ready accountability.
Let's break down this tech stack because, frankly, it is wild to see this level of technology deployed in a rural clinic.
It really is. The core of their operational tracking is an enterprise resource planning system that they have affectionately nicknamed Smiley.
An enterprise resource planning system is usually something you see deployed in massive global corporations like international shipping conglomerates or major automotive manufacturers.
Right.
It is complex software designed to integrate all facets of an operation, from real-time inventory tracking and order management to accounting and human resources.
And they have deployed this in rural Ghana. The audit states that every single physical product, every box of medicine, every shipment of syringes, every supply chain event is tracked to dedicated global positioning system coordinates.
They know exactly where every single pill is located at any given moment across the entire geographic network.
But let's look at the mechanics again. How do they transmit that massive amount of tracking data without reliable, high-speed terrestrial internet? We already established the grid is terrible.
That is where the $2,500 technology budget proves its worth. They utilize Starlink satellite internet.
Of course.
They bypass the unreliable local cell towers and terrestrial fiber networks entirely by beaming their encrypted data directly to low Earth orbit satellites. The enterprise resource planning system can asynchronously cache the data when power is down, and the moment the uninterruptible power supply kicks in and the Starlink connects, it bursts that data to the cloud.
And the audit notes that if a major institutional donor requires incredibly granular, real-time transparency, say, they want to see time-stamped, geotagged photos of the actual vaccinations taking place to prove the viral shield is active, this data can be captured on mobile software by the nurse and transmitted via that Starlink connection directly to a highly secure virtual private server.
A virtual private server provides a secure, dedicated, partitioned environment for that highly sensitive medical and operational data, keeping it safe from interception while making it instantly accessible to an auditor sitting in Geneva or New York.
Amazing.
And if we connect this back to the United Nations goal number 17, which is partnerships for the goals, we have to look at the ultimate final layer of their financial transparency.
The blockchain integration.
Yes. We talked earlier about using the United States dollar coin on the Ethereum network to eliminate cross-border banking fees and increase the velocity of money.
Right.
But the secondary and perhaps much more profound benefit of that specific technology is the immutable public ledger.
So for our listeners who aren't deep into crypto, the blockchain is essentially a digital receipt that is mathematically impossible to alter, forge, or delete once it is written.
Exactly. When an institutional donor sends funds using this method, the transaction is permanently recorded on a public blockchain. It provides an unbroken cryptographic record, proving to the entire world that the specific funds moved from the donor's wallet directly to the operational wallet of the specific rural health hub.
Wow.
There is no middleman, no corrupt local official, no opaque administrative layer who can skim 10% off the top without it being permanently glaringly visible to anyone who audits the ledger.
It is the ultimate technological weapon against corruption or bureaucratic leakage.
In a philanthropic landscape where aid money frequently and tragically disappears, creating an unbroken real-time data chain from the donor's bank account directly to a remote village's inventory shelf is a massive, overwhelming competitive advantage.
I can imagine.
If you are a grant writer, competing for limited philanthropic capital, and you can offer blockchain-verified, global positioning system-tracked, satellite-transmitted proof of absolute impact. While the competing organization is just offering a promise and a glossy brochure, you're going to win that grant every single time.
And Give Basic Needs doesn't just dump this complex Starlink and enterprise resource planning technology on the registered nurse entrepreneur and walk away hoping she figures it out. The foundation acts as a dedicated tech partner.
Right. They provide a comprehensive software-as-a-service back-end package.
So what does that software as a service package actually entail for the daily life of the local clinic?
It includes establishing a professional digital presence through dedicated website hosting. It includes integrated accounting and bookkeeping software to manage those complex year two revenue streams from the medicinal forest.
Okay.
And crucially, the audit highlights that it includes private branch exchange phone routing.
A private branch exchange system, so advanced corporate call routing. Why does a tiny three-room clinic need the phone system of a mid-sized corporation?
Because the ultimate vision is not to remain a tiny three-room clinic. The goal is to aggressively scale into a full-fledged regional hospital.
Ah, I see.
A private branch exchange system allows the hub to efficiently manage a high volume of patient calls, read emergency inquiries to specialists, and crucially maintain seamless, high-quality consultation lines with the central Tamale Command Center.
It makes a rural, remote outpost operate with the communication efficiency and professional veneer of a major urban hospital.
It's digital scaffolding. They are providing the technological framework for massive future growth from day one.
Which brings us perfectly to the final and most crucial piece of the investment puzzle. We have explored the mechanized water, the empowered nurses, the heat-stable vaccines, the commercial forests, and the satellite data. Now we need to bring all these complex threads together into the final, undeniable pitch for the philanthropic donors.
The grand finale of the narrative. The audit defines this as the dollar challenge matrix.
The dollar challenge matrix. This is the distillation of every single concept we have discussed today into a clear, unforgiving, institutional-grade metric. It is the ultimate mathematical answer to the single most important question any donor asks, which is, what exactly do I get for my money?
It provides a quantifiable, verifiable return on investment for humanitarian spending. It literally links every single dollar spent to highly specific, measurable, on-the-ground outcomes.
Give me an example.
When a donor looks at the dollar challenge matrix, they aren't just funding a vague concept like health improvements in Ghana. They are funding a specific, guaranteed number of vaccinations administered. They are funding a specific number of early-stage preventative screenings completed.
And a verifiable tracked number of clean water liters provided to the community through the borehole.
Exactly. It commoditizes the humanitarian impact in the best possible way. It strips away the emotional manipulation often found in charity pitches and makes the abstract concept of doing good intensely concrete, mathematical, and auditable.
And what should stand out to any institutional grant committee reviewing this matrix is the absolute modularity of the design.
The scalability here is breathtaking. Donors are not forced to throw millions of United States dollars into a giant pool hoping something positive happens in the region.
Right.
They can fund a single contained modular footprint, one health hub, one borehole, one nurse entrepreneur for exactly 171,000 United States dollars.
Or if they have the massive capital deployment requirements of a major sovereign wealth fund, they can fund an entire regional network of 10 or 20 hubs.
Yes. And because the system is perfectly standardized, it uses the exact same clinic architectural design, the exact same enterprise resource planning software, the exact same vaccine protocols. The cost structures are perfectly predictable.
So if Hub A costs exactly 171,000 United States dollars to launch and reaches financial independence in year 2, the grant committee knows with absolute mathematical certainty that Hub B, built 50 miles away, will cost the exact same amount and follow the exact same operational arc.
It removes the massive, terrifying variable risks that are usually associated with frontier infrastructure development.
So when we pull all the way back and look at the entirety of the Northern Health Shield investment case, what is the ultimate value proposition for the global development community? What is the core truth they are selling?
The ultimate value proposition is the total eradication of dependency. It is a profound structural shift from viewing people in developing nations as passive, helpless victims who need to be continually rescued by foreign saviors to viewing them as highly capable, intelligent entrepreneurs who simply lack the initial physical capital and the digital scaffolding to build their own resilience.
It's an investment in sustainable, sovereign infrastructure that physically and financially pays for itself starting in year 2. You aren't buying them medicine forever. You are buying them the factory that allows them to generate their own medicine, their own commercial wealth, and their own absolute health sovereignty.
It completely redefines what modern humanitarian aid must look like in the 21st century. It is mathematically rigorous, it is technologically advanced to the highest degree, and above all, it is deeply respectful of local human dignity.
Which brings us to the end of our deep dive today. Let's quickly recap the massive complex ground we have covered.
We started with the foundational behavioral philosophy. Happy people solve problems more quickly, and how that manifests mechanically in the physical anchor asset of a mechanized borehole.
Providing free, uncontaminated water to lower the friction of healthcare and build deep community trust.
We moved to the human element, detailing how Give Basic Needs empowers the 45,000 unemployed professionals by turning a female registered nurse into an autonomous healthcare chief executive officer.
Supported by a one-time capital grant and a strict, heavily debated one-year stipend cliff to aggressively force self-reliance.
Then we unpacked the incredible multi-sectoral alignment with the United Nations Sustainable Development Goals. We detailed how a single hub increases the velocity of money through local employment.
And leverages the United States dollar coin on the Ethereum network to bypass predatory international banking fees, and utilizes localized, uninterruptible power supplies to outmaneuver failing national electrical grids.
We explored the clinical biological science of the four-layer defense shields, particularly diving into how high ambient temperature stable vaccines completely eliminate the fragile, expensive dependency on a continuous refrigerated cold chain in rural environments.
And finally, we analyzed the digital nervous system, the Smiley enterprise resource planning software, the low Earth orbit Starlink connectivity, and the immutable blockchain ledgers that provide absolute, unbroken transparency to institutional donors.
All summarized in the perfectly predictable return on investment of the dollar challenge matrix.
It really is a masterclass in systemic, multi-layered problem solving. It makes that traditional murky landscape of global aid we talked about at the very beginning, the black box of unaccountable charity, seem entirely obsolete. We're looking at a precise, data-driven, mathematically sound blueprint for actual permanent change.
It provides the hard engineering precision that the global development sector has been desperately lacking for decades.
So as we wrap up this deep dive, I want to leave you, the listener, with a final provocative question to ponder. We have seen how incredibly effective and resilient this specific intervention can be in northern Ghana. So ask yourself, if a localized, technologically advanced, women-led cooperative model can successfully replace massive, inefficient international aid logistics in rural healthcare, what other seemingly unsolvable global infrastructure problems, whether it's housing, education, or agriculture, could we fix simply by giving local entrepreneurs the right anchor assets, securing the operational data on the blockchain, and then having the courage to just step out of their way?
That is the real challenge matrix we all need to solve next.
Until next time, keep digging deeper.